It's quite clear by now that immuno-oncology is a new pillar of therapy for advanced cancers. We've known a long time that the immune system could attack the cancer, but it only worked anecdotally. Now, by understanding the biology of how the immune system relates to the cancer, we now have drugs that actually unleash the immune response to get the immune system to attack cancer specifically. We're seeing unprecedented levels of long-lasting responses in patients in multiple cancers, including the ones where the PD-1 class of drugs are being approved: melanoma, lung cancer, Hodgkin's disease, renal cell carcinoma, but in many others. There's around at least 15 cancers where there's activity, and we've tested in many more. The broadest applicability of immunotherapy this time for cancer is the PD-1 or PD-L1 blocking antibodies. By themselves, as single agent, they have very low toxicity profile. It compares favorably to any other treatment that I've ever tested, to chemotherapy, to radiation therapy. These are low toxic agents. They very specifically unleash T cells that are attacking the tumor, as opposed to T cells that attack other parts of the body. A prior generation of these agents, the CD4 blocking antibodies, had a little bit broader toxicity because they work upstream. It's when they work when the immune system is being turned on, so they can turn on immune system cells that can attack different parts of the body, including the cancer. The PD-1 blocking antibodies act at the site of the T cells inside the tumor and only unleashes them. That's why the toxicity profile is in between 10 to 15% of grade 3 to 4 toxicities, much better than the older immunotherapies. The premise of immunotherapy is that once we get the immune response to attack the cancer, it should have memory. It should lead to long-lasting responses because the immune system remembers. We were interested in immunotherapy for cancer for many years, but it only worked anecdotally. Now, with the PD-1 and PD-L1 blocking antibodies, we're having higher frequencies of durable, long-lasting responses. In my clinic, it's made a big difference. I work in melanoma. I used to have a clinic that had a steady number of patients. Unfortunately, whenever I had new patients, all the patients were not coming anymore. Now, my clinic is going up. I'm accumulating a lot of patients that keep coming back and coming back, getting treatments or are off treatment. And instead of having a deadly disease, are now seem to be having normal life for 3-4 years and going on. Biomarkers for activity of PD-1 and PD-L1 blocking antibodies are obviously of great interest. If we were able to select the 1/3 of patients who respond to single-agent PD-1 blocking antibodies, either pembrolizumab, nivolumab, or the PD-L1 blocking antibodies, in this is in melanoma, we were able to get then 100% response rates. I think we have the information to do this, but it's hard to apply to the clinic, because it's not only PD-L1. PD-L1 is important whenever it's reactive to the presence of T cells in the tumor. So if you're looking for PD-L1, the next question is, are there immune system cells to be unleashed? If there's PD-L1 and no immune system cells, there's no point in unleashing them. If there's immune system cells that do not trigger the protection of the tumor by PD-L1, also there's no need to unleash them. But then the immune system cells need to find something that's wrong in the cancer, need to differentiate the cancer cells from the normal cells. So then we start thinking about biomarkers that we in the cancer, like mutational load. The more mutations, the more likely the immune system has tried to attack the cancer specifically. We should be able to put it together, but there's no assay that's ready for clinical use at this time with this. PD-L1 biomarker alone, I think it's not enough, and it only gives partial information that can enrich the population for response, but will not tell us which patient is going to respond or not. In melanoma, the approvals of pembrolizumab and nivolumab have been regardless of the biomarker of PD-L1. This is because early on it was clear that patients with PD-L1 negative tumors could respond. And also we could see a percentage of patients with PD-L1 positive tumors did not respond. I think that's because it doesn't capture all of the complexity. We need PD-L1 and the presence of immune system cells to be able to make sense of what does PD-L1 positive or negative mean. Also, scoring of PD-L1 is usually done in the whole slide, as opposed to looking specifically in the area where the immune system is trying to attack the cancer. and the cancer can try to protect itself through PD-L1. So I think it's a biomarker that it's not used in clinical, in the field of melanoma, not only because of the clinical experience that not support it, but I think the biology of it does not support using it as a single marker.